Test 1 2 1 2. Test 1 2. Test 1 2. Testing 1 2 3. Testing 1 2 3. Testing 1 2 3.
I believe they do.
Yeah, I was out there about 1960 in a residency at the University of Colorado, and there was a small facility down the street a couple of blocks that was a
There was, I think there was one maybe a long time ago, and then there wasn't one when I went to school, and then I think when we finished up, when I was finishing up, they were opening a school there.
Yeah, we would get there, frantic calls, help, we're sending somebody over to you, that type of thing.
Yeah.
To the emergency room that was in acute distress.
Sure.
So those were a long time ago. That's when automatic processing was just first coming in, and the government, the VA hospitals, there was a crooked thing going on. A company that didn't exist 3 months before suddenly popped up, and a senator and some businessmen apparently were involved in it, and they bought these processors for all the VA hospitals in the United States. In 3 months,
When Haiti and the Dominican Republic all got hit by that hurricane, and that one electric company from like North Dakota that just popped up a few months before, it got the whole contract initially.
oh, what they did then, they took all those processors out and bought either DuPont or Kodak processors, which were the genuine.
Yeah, legit stuff.
So that's how,
Yeah.
and quietly, nothing
Right.
nothing got in the papers about it.
Of course, of course.
It's one of those little things.
Yeah.
Where you steal $500 million,
Yeah, I worked for CDC for 2 years, and I saw contracts like that. Not that big, but
For the CDC in Atlanta.
Yeah.
I took my residency in radiology at Emory.
Okay, that's where I did my fellowship at Emory.
At Grady Hospital.
Yep.
And then I had 2 years practicing in the Navy, and very heavily. We were at Long Beach, California, and it was the Pacific Fleet Command at that time. And every time the ships came in, all the dependents flocked in.
Yeah.
We were seeing like 1,000
Oh, sure.
dependents a day, 6 of us.
It's like a beach resort. We're busy certain times of the year, and then
It was great for everybody but us.
yeah, exactly.
Even the Army had a facility there, and they closed at that time and sent them over to us.
Wow.
For the night. That's one of the reasons I, of course, didn't go Navy.
See something quick. All right, I'm gonna step up front here, but it was nice talking with you. Is there anybody that's gonna introduce me, or do I introduce myself? Okay, just say go. Okay. Sydney.
Don, are you ready? Go ahead.
Okay. Welcome. My name is Justin Arnold. I am one of the assistant professors over at UAB, your friendly neighbor. And we're going to talk today about recognizing prescription drug abuse.
Excuse me, could it be a little louder?
Sure.
I don't think, if you have a microphone, I don't think I
I have one. Is that any better?
feel that, yeah.
A little bit?
Thank you.
Okay. So my name is Justin Arnold. I'm one of the assistant professors over at UAB in emergency medicine. And I'm happy to talk to you guys today about recognizing prescription drug abuse. I have no conflicts. I wish I did, but I'm not that privileged yet. So our goals today are going to be to talk about at-risk populations, at-risk medical conditions, and at-risk medications to kind of alert you to patients who are at risk for prescription drug abuse. We're going to talk about the physician's role, responsibility, and their attitudes in appropriate prescribing, and that's important. We're going to try to identify behaviors that may suggest drug abuse, and these are things that you can pick up on to kind of clue you in again. And we're going to try to understand the appropriate and inappropriate responses to patients who present with drug abuse concerns. So the first question we have to ask is this a problem? This is kind of a, is that really loud? Okay. So the first question we're going to ask is this a problem? And this is kind of a redundant question to ask because this is a big problem, right? So we know that since 2011, we're getting close to 1.5 million ED visits related to prescription drug abuse and recreational drug abuse. These are things like falls from being on prescription drug abuse. This is overdoses, psychiatric concerns, things like that. We know that since 1999, we've seen a almost quadrupling of overdose deaths. And I think if you look in this last year, because this is older data, that's probably even exponentially higher. And the National Institute on Alcohol Abuse and Alcoholism estimates that, and this is looking at all drugs and alcohol combined. There's a lot of noise here. That there's over 100,000 deaths and $100 billion per year that can be attributed to alcohol and drug abuse. So it is certainly a big problem, and that's probably not surprising to most of you. What does this actually cause when we look at people and the impact on people and their families? Well, we know it has a pretty profound impact on people's relationships with family members and friends. We know that it has a big impact on work, missed days at work, poor performance at work, failure to advance. We know that students, who this also impacts significantly, have a big impact with prescription drug abuse in particular. And we'll talk more specifically about that. So the next question is, who is at risk? And what substances really are the risky substances when we talk about prescription drug abuse? This was surprising to many people when I talk about this, but addiction is a very widespread problem. And based on the setting that you're at, you may be surprised to find the number of people this affects. So studies have shown that it's probably closer to 30% of patients who are primary care patients that present to your office probably have some form of addiction. And this oftentimes includes alcohol and tobacco as well, but prescription drugs are a part of that. Up to 50% of people who are hospitalized have addiction, and that is probably, again, not surprising for people who work in the inpatient setting. And again, probably not surprising, psychiatric patients tend to have a really high comorbid rate of prescription drug abuse. And then, again, not surprisingly, a lot of people have chronic pain as a cofactor here. So 87% of patients who screen positive for illicit drug use report chronic pain. So that's a big, big risk factor.
My computer's been messing up too, so.
Should I say hi to these people? Okay. And so the three big things I want you to think of as far as medical conditions that should raise your suspicion, or at least just make you consider prescription drug abuse in particular, are chronic pain, not surprising, anxiety disorders, and ADHD. And this largely correlates.
Well, I just want to log on to Google Chrome real quick.
All right. We're alone now. Okay. And this largely correlates to the substances that these people are prescribed plus the underlying condition. So not surprisingly, again, the substances that are most at risk or place people most at risk for developing prescription drug abuse are opioids, sedative hypnotics like benzodiazepines, sleep medications, barbiturates, and stimulants. Okay? And all of these work by triggering the dopamine release in something called the mesolimbic dopamine pathway. And this is a pathway in the brain that largely functions on reward and motivation, okay? And it also involves inhibition in the frontal cortex. So this pathway, once it really develops, it really rewards pleasure, and it starts to disinhibit you to things that would prevent you from seeking that pleasure. The drugs, again, that we mentioned that are characteristic of or high risk for drug abuse also have some specific characteristics, right? So drugs that have a very rapid onset of action, brief duration of action, and high potency. A great example is heroin, right? Heroin, real fast, goes away real fast, and is very potent, or fentanyl for that matter. But there's a lot of prescription drugs that are like this too. Drugs that are high in purity, drugs that are highly lipophilic, so drugs that will cross the blood-brain barrier faster, will give you that high faster. Drugs that are highly water-soluble, on the other hand, actually are easier to inject if you crush and inject them. And then drugs that are highly volatile are easy to smoke. And all these are routes, IV, inhalation, routes that increase how fast a drug is absorbed. Usually, most drugs that are abused typically have a withdrawal syndrome associated with them. And that's largely tied to the drugs how the drug kind of changes one's receptors. You'll downregulate cigarette receptors, you'll increase tolerance, and when you take away a drug, your body kind of feels that. And all these drugs typically have a value on the street, okay? There's a reason that Lasix is not going for $1 per milligram on the street, like some of the other prescription drugs are. Maybe it does. This is the current DEA scheduling, and the DEA came up with this schedule in an effort to classify drugs by their abuse potential and their medical utility. And so Schedule I drugs, for those who aren't familiar, are drugs that are deemed to have no medical utility but high risk for abuse. So drugs like heroin, ecstasy, marijuana still is a Schedule I drug right now. Schedule II drugs are probably the risky drugs that we think of when we think of drugs that we are really careful or hopefully careful about prescribing. These are drugs that do have some, and I would argue have a lot of medical qualities, but they do have a tremendously high risk for abuse. And these are things like Vicodin or hydrocodone, cocaine, meth, OxyContin, and Adderall. Schedule III drugs, again, have a moderate abuse potential. These are drugs like Tylenol with codeine, ketamine. Schedule IV is a lower abusive potential, things like Xanax, Darvon, which is not available anymore, Valium, Ativan, Ambien. These are kind of the sleeping drugs and the lower tier pain medications. And then Schedule V drugs are the lowest abuse for potential, but they still do have an abuse potential. Okay. So what is our role when we talk about prescribing these medications and monitoring for drug abuse? Because we have a bigger role than you may imagine. So, physicians and all healthcare providers have a role for legal, ethical, and professional responsibilities to uphold the law. So there are pretty significant laws for how these drugs are prescribed, how they're used by patients and individuals. We have a responsibility to protect society at large from drug abuse because we're the ones that are just prescribing these medications. We do have more control than you would imagine. We have a responsibility to prescribe these responsibly. And then we also have a responsibility to protect organizations from being the targets of diversion. And so if you look at some of the kind of classic pill mill schemes that have happened in the past, there's usually, when you look at this and from when the DEA does these studies, they usually find that there are certain organizations that collectively are really high prescribing organizations, and it's almost a cultural way to prescribe. So we always prescribe this, and this is how we always treat pain. And I would encourage you to kind of break that mold a little bit and kind of think just in terms of the individual patient. And the challenges are that we want to do good for the patient, right? We don't want to underprescribe for patients who need appropriate pain medication. We don't want to stigmatize patients who have high opioid requirements, for example, and some individuals do. If you think of like a kind of a classic would be a very advanced cancer patient who's got a lot of pain, has been on opioids for a long time, has built up tolerance. They may be on very high doses that if you just meet them for the first time and say that's too high, you may be kind of inappropriately stigmatizing this person as someone who's abusing their drugs, and that may not be the case. And then you have to remember that although this is a huge problem, most people you prescribe to do use these drugs appropriately. So again, we don't want to label everyone as a drug seeker, a drug abuser. We want to treat the people who need it, and we want to not give these medications to people who are going to abuse it. The flip side to this is that it's also kind of a risky thing for both patients and for physicians, this whole business, right? So physicians are potentially under sanctions for their license by the DEA, and then there's also legal ramifications that can occur if you overprescribe. I'm not sure if everybody's kind of followed the news. There's been a physician recently, actually several, that have been actually sent to prison for prescribing medications that resulted in the patient's death. So it's really high risk for someone who's, I'm happy to be a physician and I like what I do, but this is really risky stuff, right? And then of course, patients, we don't want our patients to overdose. We don't want them to die from these medications that we're trying to give them to help. Now when you look at the typical 4 kinds of physicians that are at risk for overprescribing, there's a concept called the 4 Ds of overprescribing, okay? The first is dated. And so this is usually a physician who is not keeping up. They're planning on letting their license expire after this cycle. They may not be familiar with current methods in treating pain or new medications that are coming about, or they're just not familiar with the medications that they are prescribing, okay? Duped is the second one. There's probably a little bit of all of us in this kind of patient here, in this physician. So all physicians, typically, most physicians are pretty caring individuals who really are trying to do the best things for their patients. And so it's easy if a patient comes in and they've got a sad story and they have a lot of hardships that you want to try to help them out. And so duped is the second one. Dishonest, hopefully this is not anybody in this room or anybody listening, but there certainly are physicians and prescribers who will try to make money off this very lucrative market. So there's a big need or a big want for these medications, and physicians can find ways to make a lot of money off this, unfortunately. And then disabled. This one's kind of the most interesting to me. So this is the physician who may have their own addiction. They may have their own personality disorder, and they fear that if they expose someone else's addiction, that individual will then expose them. And so it's a very kind of quiet of the 4 Ds to overprescribe, but it's kind of a fear of being found out. So recognize that these are kind of the 4 highest risks for overprescribing. And I think all prescribers, no matter if you're overprescribing or appropriately prescribing, you have to recognize a little bit about yourself. And this is probably not the most, it's probably not what you thought you were going to hear when you came here today, but there's 2 concepts I think that are important, and one is called countertransference, and this basically says when you develop a relationship with someone, and a patient in this setting, so as a caregiver, your attitudes change based on that relationship. And this happens in every patient encounter, no matter if you're prescribing opioids or benzos, not. So this influences your interaction with that individual. The second is codependence, and this doesn't happen with everyone, but this is a characteristic where you are involved with usually a very sick person, and your relationship changes such that the normal barriers that would exist don't. And so you start to do things for that patient that you wouldn't, and oftentimes this is a relationship that feels beneficial to both the patient who's getting the attention they want and feels good to the physician who is acting as the helper. So it's kind of this reinforcing relationship, but it breaks down normal barriers in a doctor-patient relationship, and oftentimes people will start to do things that they wouldn't normally do with other patients, okay? And then the other thing too is the codependence really leads to, and people who have a problem with addiction are really good at making their problem your problem. They shift that problem onto you, and they make you feel the whole weight of that problem. And that's really reinforced with the codependent relationship. So how do we actually recognize prescription drug abuse? I'll tell you, it's oftentimes subtle, but it's there if you look. There's a great document that was put out by the DEA called Recognizing the Drug Abuser. You can download it, it's free. It's like a trifold kind of document. And it describes kind of how people go about obtaining drugs when they're addicted, as well as common characteristics of these drug abusers. And you may see these in your patients. And then it also talks about how to respond. And so we'll actually kind of talk about this document, because I think it's really a great document. So most patients that come in with a problem of addiction who are actively trying to get you to prescribe medications will have some of these characteristics. And these are how they go about it. So a lot of times they need to be seen immediately. So there's some urgency to how quickly they need to be seen. That kind of elevates the severity of their condition, at least in their mind and probably in your mind. They typically want appointments at the end of the day. And this is because when they come in at the end of the day, there's not much time left. You're usually tired from the whole day. You may not put as much effort into counseling the patient or obtaining records or things like that. So they're counting on that fatigue to kind of set in. They'll state that their doctor's not available, or they'll refuse to provide information on their previous doctor or whoever referred them or was seeing them last. Oftentimes you'll hear this is the person that comes traveling through town and says, I came through town and I don't have any of my medications and I'm not going back for a week, right? They'll kind of give that story, which may be true, but not always. They tend to feign painful conditions, which is really hard for us to assess, right? There's not like a clinical test for a lot of painful conditions that we can really say, yes, you're telling the truth, or no, you're not. They also feign psychological conditions because, again, someone can appear very anxious, and there's not a test for me to do to prove that they're not as anxious as they say they are. They'll tell you they have allergies, and probably some of those allergies, or that non-narcotics don't work, or that they've had prescriptions that have been lost or stolen, right? That they're already on this, but it's lost or stolen. The characteristics, so that's kind of how they go about obtaining some of these medications, but the common characteristics too, they'll have really odd behavior in their waiting room. So these patients will show up and they'll pace back and forth, or they'll keep checking in to see when they can be seen. They typically have an asserting or demanding personality, which is hard for many of us to deal with because, again, we're trying to develop a relationship with our patients and they're kind of being very aggressive. And then the patient either has a pretty extensive knowledge of their drugs and their medical history, like beyond what a normal person would have, or they have a really evasive or vague history, right? So someone who says, oh, I had a total hysterectomy 2 years ago. And then you'll ask any of the details and you say, oh, I'm not sure why I had it. I'm not sure who did it. I'm not sure where it was done. I'm not sure if they did anything else. They'll give those kind of answers. Patients oftentimes will have no regular doctor, which again is problematic because a lot of patients don't have doctors nowadays. And then they may really exaggerate their complaints to try to get you to think that they're more serious or more impactful than they really are. They may make comments, particularly about the dose requirements of the medications, and that should be a big warning sign when patients tell you that only Oxy-10s work for them. So specific doses. They may use prescription drugs from their family members, so they may come in and say, I was out mowing the lawn, and I fell into a hole, and I took my brother's Percocet, and he gave it to me, and I felt that worked really, really well. So people that use other people's prescription drugs, that's a big warning sign that they may have an addictive personality to them. They may pit one physician's treatment against another. They'll say, this doctor I had before was no good. I know you're a much better doctor and you're gonna help me now. So they kind of make you feel really good. Or the flip side is they'll challenge to find a smarter, more caring physician. You don't care about me. I'm gonna find somebody who does know what they're doing, who's much more caring, something like that. People can also often offer bribes or sex, and that seems really crazy to me, but apparently that does happen. And then patients can be frankly threatening, right? So we know there's been stories in the news of physicians who've refused to give pain medications, who were shot in the parking lot after they left work. And so that's a pretty extreme example, but there's definitely patients that are threatening. And as someone who works in the emergency department, I feel like that's almost every shift. Someone yells at me for not prescribing something. Doctor shopping is a concept that, fortunately, I think we're actually getting a little bit better at containing. So this is when patients use 2 or more doctors or physicians to obtain excessive amounts of a prescription medication. And patients will typically role play different people. So they'll go into the ER and they'll complain of an acute complaint, then they'll go to a primary care doctor's office and complain of chronic pain or a psychological complaint, or whatever the case would be. And traditionally, these have been pretty difficult to detect because we didn't have any early records, but we do have something now called the Prescription Drug Monitoring Program, and that's been a game changer, I think, in identifying these people. And I use this, I mean, I will tell you, I honestly use this every time I prescribe an opioid in the ED, because I don't know anybody that shows up to my ED. Most people I don't know. I know some people. But most people that show up, I don't know. So I'm going to check and see if their story is checking out. And I love the Prescription Drug Monitoring Program. HMOs are also monitoring this. They're monitoring total doses of opioids, for example, and benzodiazepines. So if you go over so many morphine equivalents per month, you'll get a letter and the other prescribers will get a letter. So that's pretty helpful. And actually, chain pharmacies are starting to pay attention too. I got a letter from, I think it was CVS, that they're going to start to monitor total morphine equivalent doses in their patients that get filled at CVS pharmacies. So this is getting better, and it's harder for people to doctor shop than it was, but it still certainly it happens still. All right, so let's talk about some abuse red flags, and these are kind of the signs that I wouldn't want you to miss, hopefully. And the caveat to this whole thing is that this is subtle, okay? If you're not paying attention to this, you will miss this in your busy day, right? So this is not someone who comes in with track marks in their arm, and I can say, when was the last time you shot heroin? And they say, before I got here, right? These are people who have pretty normal lives for the most part. And really the only thing that you may have is a noticeable pattern of behavior over time. And so this puts someone who, especially as like a primary care doctor who has frequent contact with the same person, at a real advantage over someone who's like a consultant or an ED physician or something like that only sees, or a hospitalist that sees these persons, once in their life. So people may come in and they may tell you that they are frequently missing work for their complaints. They have a lot of falls or accidental trauma, right? So someone keeps coming to your office because they're klutz, and they keep falling, but they need pain medications whenever they fall, right? They may have a history of depression or anxiety, and again, that's not to stigmatize anyone with one of those 2 disorders, but those are high-risk patients. They may have labile hypertension, right? So you have a patient that you start on blood pressure medications, you bring them back to the office, and this should be working, right? And their blood pressure's way sky high. Well, maybe they're an alcohol withdrawal. Maybe they just did cocaine or meth before they came into the office. Those are real things. And so you'll keep trying to titrate their medications, but it's high, and then when they go home, they complain that they're passing out or feeling dizzy because it's low. So drugs can certainly be involved with that. Some GI symptoms like chronic pain or chronic diarrhea certainly can be related to drug use or drug withdrawal. Sleep difficulties, for sure. Sexual dysfunction is pretty common in this population. And then certainly, like we talked about in the beginning, relationship difficulties we see with people who are chronically abusing medications or drugs. I put this on here, and again, we're talking about prescription drug abuse, but I put a few physical exam findings on here of illicit drug use and alcohol abuse, because there's a high comorbid rate of people who use illicit drugs and prescription drugs, right? So alcohol abuse, if people come in with a mild tremor, labile blood pressure like we talked about, alcohol in the breath, and then some people also have something called aftershave syndrome, where they use aftershave or mouthwash to kind of hide the smell of alcohol. And then certainly if they have some hepatomegaly, that could be also another clue. Cocaine, cocaine's really interesting. So nasal irritation, some people can actually burn a hole straight through their septum. So if people complain of like a lot of like nasal irritation, you look in, there's no septum, think cocaine. And then also people can get a vasculitis, and I don't know how well it displays here, but on the bottom, most of the cocaine in the US is cut with something called levamisole, which is an anti-Helminth drug, and it causes a pretty impressive, painful vasculitis that people will oftentimes present with, not knowing what's causing it, but it's the cocaine. And then methamphetamines, we don't see a tremendous amount of meth around here, but we see some. And so oftentimes you'll see the kind of classic meth mouth, where people get a lot of dental caries. And then people also tend to pick a whole lot and scratch. So they'll have a whole bunch of scabs kind of throughout their body. Cannabis, usually conjunctival irritation is the large thing that you're going to see. They may smell like marijuana, or they may have, and we've been seeing this more and more recently, this whole idea of Cannabis Hyperemesis syndrome, where people will come in, they're complaining of intractable vomiting that's only relieved with a hot shower. And that's oftentimes associated with heavy cannabis use. And then some of your older patients, you may see them developing COPD, but they don't ever give you a history of smoking tobacco. So now that we kind of have an idea of how to look out for these people, how do we screen for this? And this is hopefully, I think that hopefully this is going to be a game changer for you. So the first thing I want you to know is we're going to screen to put people into really one of two, maybe three categories. And these definitions are important so that we're kind of labeling these people correctly. So the first is abuse. So abuse is any way that you use a drug other than how it's prescribed. So if I give you a prescription for Tylenol, 650 milligrams, every 4 hours is needed for pain, and you take it every 2 hours, technically that's abuse. If you crush the Tylenol and snort it, that's abuse. If you're taking 4 grams every time you take a dose, that's abuse as well. Usually there are adverse consequences with this. Addiction, right, is a little bit different than abuse because this is a loss of control, and this is where abuse starts to blend over into affecting other parts of your life, right? So you have a preoccupation with using this drug, and so you go out of your way to obtain the drug, to continue using the drug. Some people will buy drugs off the street, some people will steal to get money, things like that. Oftentimes with addiction, people are using a high enough dose of this, or they've been using it for long enough that they do have withdrawal if they try to stop it. And dependence, dependence is our kind of cancer patient who's on high dose opioids. So this is someone who has a physiologic change after long-term use or high dose use that's predictable and oftentimes associated with withdrawal. So usually this involves the drugs that we're talking about, opioids, benzodiazepines, barbiturates, and stimulants. And it's not necessarily the same as addiction. So someone who has a high tolerance and begins to withdraw when you taper off or suddenly stop their drug is not necessarily addicted to the drug, they just may be dependent on the drug. Now, when you screen patients, I would argue this should be the same thing as a screening for smoking, for domestic abuse, for suicidal ideations. And it's very simple to screen, but I want you to pick one tool to screen with and use it regularly. Where I think people kind of get hung up with screening for drug abuse and alcohol abuse is they feel like there's so many tools, and there are a lot of tools, that they get a little overwhelmed with which one they should use. And I'm just going to tell you one today that I think is simple and everyone can use, and it takes seconds, okay? How many times in the past year have you used illegal drugs or used a prescription medication for non-medical reasons, okay? This is as simple as it gets. This is a validated tool that was out of Boston University in 2010. It was found to be 100% sensitive for prescription drug abuse and 73% specific. Flip those two. So a really nice sensitive tool that if someone scores positively for this, you can follow up with a kind of more comprehensive tool, all right? And an answer of 1 or more, if anyone does this, okay, is a positive screen. So really simple question, does not take a lot of time. So how many times in the past year have you used an illegal drug or used a prescription medication for non-medical reasons? An answer of 1 or more is a positive screen. So that's simple, right? I think so. So you can look at other ones too, and if you go to like the NIDA website or the SAMHSA website, and if you Google like addiction prescription drug screens, you'll see a handful of these, but I think this is the simplest one. This is what I use when I see patients in the hospital, right? And then we follow this up with something called SBIRT. Well, it's part of it. So, which is screening, brief intervention, and referral treatment. And this is a concept that doesn't take more than 5 or 10 minutes to do from beginning to end, and is a very effective brief intervention. But I think a lot of people will say, well, I don't want to ask this question because if I get a positive answer, there's a lot of like interventions and referrals that has to go into this. And this is a really nice way to like make this pretty succinct. So the screening questionnaire, I would argue, if you use the one we just talked about, that's your screening questionnaire, right? The brief intervention is a short counseling session, and you don't have to be like a professional counselor or a psychiatrist to do this, but it's short, and the idea is to assess the patient's need for change and to motivate them for treatment or to change their pattern of behavior, right? And so the way you do this is you give a non-judgmental assessment and clear advice, and then you assess the readiness to change. So this may look like something where you would say, Mr. Johnson, I know you're taking, you were start off taking your oxycodone for your shoulder injury 2 months ago, but now you're actually using it more than you're supposed to, and you're buying it off the street, and that's concerning for abuse. And then you can start to ask them some questions. You know, why are you using the medication like this? What benefits does it have? What negative effects does it have on your life? And most people, from that, you'll start to quickly gauge how ready they are to change. And the change may be small. The conversation may end with you telling them, I want you to try to use less, and then we're going to meet again in a month and talk about how to decrease it. And if you want to go get counseling or treatment, we can arrange that. Or the patient may be at that visit ready to actually say, yes, I want to stop this stuff now. Can you send me somewhere? And so there's obviously we would like to have everyone stop their behavior on that visit, but realistically, decreasing use is also helpful. And you can't push people past where they are in the readiness to change. And the referral to treatment is just that, as best you can, try to facilitate the referral treatment. So people may have real barriers, insurance, transportation, things like that, or they may have perceived barriers that they can't do this, won't fit into their schedule, they can't keep a job while getting treatment. So as much as you can help facilitate them getting to the appropriate treatment, that's helpful. I want to take 1 second to talk about urine drug screens. So like I said, I do emergency medicine. I'm also boarded in medical toxicology and addiction medicine. So the drug screen is near and dear to my heart. And it's commonly misused. And this is not going to be like an extensive, I have a whole, if you want to come listen again, I have a whole like hour-long presentation on urine drug screens we give to the residents. But we'll hit the high points of this because a lot of people make decisions. Yes, this person is taking drugs, or no, this person is not taking drugs based on a pretty poor test, okay? And so with any lab evaluation, in particular drug screens, the interpretation of that screen is really critical. And you have to know more than just what the piece of paper says when it gets printed out, right? You have to know how the test is performed, you have to know the limits of detection, or roughly, and you have to recognize what the false positives and false negatives are of that test. Like I said, we kind of oftentimes take the urine drug screen as a black and white. They took Ativan and their benzo screens negative. They didn't take Ativan. Maybe not true. Okay, so most urine drug screens, and I won't speak for the one here that you guys have here because I don't know which one it is, and every hospital is different, but most drug screens are an immunoassay. They're cheap, they're automated, and they give you results pretty quickly, okay? The big limitation of that is that we have a lot of false positives in particular, and then some false negatives. So you have to know what those are. We usually use urine for most of the drug screens that we have. It has the advantage that it's non-invasive and it's pretty easy to collect, but its disadvantage is it's really easy to adulterate. There's something called a Whizzinator. It's like a penis or a bladder that people put on, and it looks like it. They can be watched and pee urine from a bag on their back. People have been known to self-cat themselves with another individual's urine and then provide a sample. So people can get around giving good urine samples. It's pretty crazy. So most urine drug screens look for things like opiates, tricyclics, PCP, cocaine, amphetamines, benzodiazepines, and THC. Some of the urine drug screens have expanded now where they will test for things like hydrocodone, oxycodone, methadone, fentanyl, but not everyone does. And so you have to know what your hospital or what your lab assay is testing for. Typically, opioids on a drug screen are testing for 4 things, really 3: morphine, codeine, and thebane. Okay, so if your opioid does not get metabolized to one of those drugs, it shouldn't test positive on most urine drug screens. Okay, and things that don't get metabolized to any of those include hydromorphone, oxy or hydrocodone, fentanyl, methadone, meperidine or Demerol, and buprenorphine, right? So it's not surprising to me when someone comes in and they've taken they bought fentanyl, for example, off of a friend, or they're taking someone's fentanyl patch, that their urine drug screen for opiates is negative. Not surprising. Heroin I put up there as a star because heroin does get metabolized to morphine. So you'll see that will cause a morphine opioid screen to be positive. THC overall is actually a pretty good screen. It's looking for delta 9 THC, and there's not many things that cross-react with that. There are some false negatives, so if people are taking a ton of Aleve, a ton of ibuprofen, or some people will actually take tetrazoline, which is like the Visine drops, and put that in the urine sample, you can get some false negatives from THC. Benzodiazepines are all based off of oxazepam or Serax. So chlordiazepoxide and diazepam. Well, chlordiazepoxide gets metabolized to diazepam, gets metabolized to oxazepam, and that's why those three drugs typically are positive in urine drug screens for benzodiazepines. But the standard kind of drug screen typically will miss lorazepam, clonazepam, midazolam, and alprazolam, so the big ones that we tend to see prescribed. And then you can get some false positives from sertraline and efavirenz. So sertraline, a very common antidepressant, can cause benzodiazepines to be positive depending on the dose that the people are on. Amphetamines are probably the worst screen of all of these. So they will pick up every amphetamine, which is, I guess, good, including all the prescription drugs that we tend to see, as well as methamphetamine and MDMA or ecstasy. But they tend to miss things. They tend to overcall, you get a lot of false positives with things like methylphenidate, dextroamphetamine, bupropion or Wellbutrin is all the time. If you're taking that at a prescription strength, that will cause amphetamine to be positive. Ephedrine and pseudoephedrine, so if you have a cold and you're taking a decongestant, chances are this will turn this amphetamine screen positive. Some antipsychotics, and then labetalol, of all things, right? So please know the test, and what I would encourage you to do is, if you're routinely ordering urine drug screens on people, to ask the lab who is providing the test, ask them for there should be like a lab sheet that they have that will describe all the false positives and false negatives for that test, and then the thresholds for those false tests. So it's pretty easy to get an idea of what your test tests for. So now that we've decided, now that we've kind of screened our patient, we've had a brief intervention with these patients, maybe we did a urine drug screen, let's talk about how we're going to respond to these people and their behavior. So how we're going to move forward with our patients, which is what I want you to do. I want you to be there for your patients, right? So I want you to perform a thorough exam. So if someone comes in complaining of a pain complaint or anxiety, do a thorough exam like you would for anyone else, okay? Check the PDMP regularly. This is a tool that if you have a medical license in Alabama, you're required to sign up for this. And it's actually just changed about a month ago, the format of it. I think it's easier to use, and it also is multi-state now. So you can check, I think we can check Georgia, South Carolina, Tennessee, Arkansas, Mississippi, and then some random ones like Wisconsin. So there's, I think, 7 or 8 other states you can check for. But check that regularly. If you're treating a patient with chronic pain in your office, I would check the PDMP when you initially start to prescribe them controlled substance, and then pick an interval every 6 months or once a year. Check the PDMP to make sure that they're not getting stuff from other people as well. Make sure you document your exam results and the questions you've asked. Probably no-brainer there. Confirm what people are saying. So call previous providers if the story doesn't make sense. Ask pharmacist questions. You can request records from another hospital, right? And then you should also make sure the person is who they say they are. So try to make sure that the person has an ID, ideally, or social security number. Keep that in their chart, and then make sure you confirm their address and their visit with each visit. And then write prescriptions in limited quantities. So don't be giving these people, 400 Percocets with 10 refills every 1 month or something like that. Just be responsible when you're prescribing. Please don't take the word for it if you're suspicious. If you get that spidey sense that something is wrong, follow that. And you've got lots of ways to do that now. Make sure you don't dispense medications to just get rid of patients. I can tell you in the ER, I would say this is a common pattern, but I think all of us have that patient that just kind of like angers us or gets under our skin or makes us anxious. And sometimes it's easy just to prescribe something to make them happy until the next time. Don't do that. And then make sure you prescribe, dispense, and administer these drugs within your scope of practice. So if a patient comes in and they're asking you to prescribe them high doses of medications for a pain complaint and you don't do that, or if they've got 4 different psychiatric complaints and they're seen by a psychiatrist and they want you to add on some Xanax, that's probably not the kind of patient that you want to be doing that with. Okay? And so, trying to conclude here, right? So this used to be the drug dealer. This is what used to be where you would get your drugs, right? On the street. If you look at like the 1980s commercials, you're bringing on drugs, this is the guy you would buy it from. But now, this is where people are getting the drugs from, right? They're getting the drugs from their parents' medicine cabinet, they're going to pill parties, they're buying drugs off the street, right? And this used to be the face of the drug dealer here, right? And now it's not. Now we're seeing that, there's elderly couples that are taking their prescription drugs and selling them on the streets to pay for the rent, right? Because they don't have enough money. And this really happens. There's kids that are, again, raiding their parents' prescription medicine cabinets. And it's all walks of life, every group. So this is a pretty widespread problem. So in summary, what I want you to do is make sure you screen everyone. Pick a tool to screen. And the one that, again, I like is how many times in the past year have you used an illicit drug or a prescription medication for non-medical reasons? It's simple and very sensitive. Make sure you assess people and consider prescription drug abuse, especially in patients who have a history of chronic pain, anxiety, and ADHD, people who are on medications such as opiates, benzodiazepines, barbiturates, and amphetamines. Use the SBIRT and look into this a little bit more. It's a great tool to provide a very limited intervention that's very effective as an intervention. And sometimes you're the only intervention this person may have, the only opportunity for it. So it's a great tool to have. Make sure you know the limitations of a urine drug screen or any drug screen that you do for that matter, and just don't accept it as black and white. And then make sure, most importantly, that you kind of look at yourself and understand your own prescriber vulnerabilities. Again, countertransference is something that's real, and it's in every doctor-patient relationship. Codependence may be something that's an issue for some of us, and I think if you recognize that in yourself, you may find that you're maintaining some of the normal relationships that you have with patients. Okay, and check and have regular checks in your practice as well. So make sure you're prescribing to the people who you think they are. Check the PDMP regularly, and certainly write within limited quantities. And that's it. Are there any questions? Or what questions do you have?